And now I am very, very happy to introduce our presenters for today. Carla McMillan is Associate Director of Finance at Cedars-Sinai Comprehensive Transplant Center. She's been at Cedars-Sinai for 20 years. And when I asked her her favorite part of her job, she said it is the opportunity to work with an exceptional and passionate clinical team while serving as a beacon of light, hope, and resourcefulness to our transplant patients and families. Oh, I love that. And supporting her in the QA is Martha Alonso, the lead transplant financial analyst for the kidney pancreas program at Cedars-Sinai. She's been there for 18 years. We know you must love it there. Both of you have been there so long. Favorite part of her job, working closely with patients to provide financial education and peace of mind that they will be okay for their transplant journey. I can't imagine doing any other job, she said. So the patients at Cedars-Sinai are so lucky to have both of you helping through what must be a very stressful and overwhelming part of their kidney journey, navigating finances of their transplant. So thank you both for coming to share your expertise with us. And Carla, I will hand it over to you now.
And thank you, Doris, for that wonderful introduction. And I'm excited to see attendees from all over. And I'd like to thank you all for your gift of time to participate in this webinar. And I believe that you will find this information very useful to the patient community and to patients themselves. So let's get started. So my presentation today is a part 2 of a previous presentation for patient financial considerations in kidney transplant.
Carla, excuse me,
Yes.
You're in presenter mode.
Okay. Okay, it's better?
Hang on.
Not just yet.
Okay, we're going to do that.
Funny how that works in our practice and not now, but yeah, try that swap one more time.
Okay, so I did the swap. Okay. So in the swap mode, is it now showing?
We're not there yet. Try display settings and swap. Okay. And yep, hit that one more time.
So I did the swap settings again.
Okay, it's not. Huh. Okay. Not quite sure why. Maybe for now, I don't know if you're able to minimize the smaller by dragging over the line.
Or maybe try exiting.
So I'm in the, just
exiting
exactly what we did. It's display settings, swap presenter view and slideshow.
Yeah.
And I've done that. On my end, it's looking like what it did. So I am in that swap mode. What are you seeing on your end, please?
Still the presenter mode.
Still presenter view, yeah.
Do you want me to share my screen, Carla, and you can just tell me to forward?
Yes, please.
Why don't you go ahead and unshare?
Okay.
All right, everybody cross your fingers.
Okay.
Let's see here. How's that?
Okay, that's
right.
fine. So I can cue you to the changing.
Yep, just let me know.
To advance the slides. Okay, great. Thank you. So thank you all for your patience, and we can advance to the next slide, please. As you all know, kidney transplant is a serious commitment and expensive undertaking. It's a partnership between you, patients, caregivers, your physicians, transplant team, and financial coordinator through all 4 phases of transplant care. And the 4 phases of transplant care are evaluation, medical management. Medical management is considered that period of waitlisting and health maintenance prior to an organ offer, the transplant admission, and post-transplant care that extends for 1 to 3 years and onward after your transplant. Next slide, please. So when we think about kidney transplant, obviously we're thinking about the care, but we also think about the cost of care and what that means to patients. And so I thought this slide, excuse me, would be informative in terms of looking at what the cost of an average kidney transplant. And it's $300,000 to $500,000. And that varies according to the geographic location of the transplant center, the recipient comorbidities or complications, and the duration on the wait list. And so that $300,000 to $500,000 and a breakdown includes the hospital admission. It includes procurement. Procurement is acquiring of the organ and any transportation or associated costs of the donor, whether it's deceased or living. 180 days after transplant, and it could be longer. And those are clinic visits, labs, medications, and 30 days prior to transplant, and sometimes it's even more than that, as well as your medications, immunosuppressants, and then your physician bills, which are also during the transplant and also any other post-admissions that could occur in the transplant journey. So $300,000 and $500,000 is representative of billed charges. Next slide, please. So in that $300,000 to $500,000, this slide is representative of what is comprised in these charges. There are admissions, hospitalizations, readmissions. There are clinic visit and testing, bills that are covering those services, your medications, your co-payments, immunosuppressants. As I mentioned, hospital bills and physician bills. There are two components to the billing process. There is transportation, whether it's air travel or any other transportations. It's gas to and from maybe dialysis centers, to and from the hospital and visits. It's parking and fees associated with that. Relocation expenses, if that's applicable, traveling and lodging, disability and loss of work. Also, there are medications very specialized, which is desensitization therapy for patients who have higher antibody levels and may need to also come in with for infusion. Excuse me, I do see someone making a comment about volume. Is volume okay?
Yep, volume's okay.
Yes.
Okay, just wanted to make sure. And then lastly, deductibles, co-pays, premiums, and coinsurance. These are share of costs that are transferred to the patient for all of this related care for kidney transplant. And this could be very overwhelming and daunting when patients are embarking on this health journey to understand, financially, am I able to, handle all of these charges and expenses that might be put before me? Next slide, please. So at the beginning of the kidney transplant journey, there's a process called a referral. And the referral is a physician makes a recommendation that the patient can continue on to this journey to transplant. And the referral can come from a number of sources. It can arise from the dialysis center, social workers, local in and out-of-state nephrologists, health plans and medical groups, or the patient can self-refer, even international help. Yes, international patients may also be eligible for even living donor or transplant internationally. And that is the gateway into the transplant center. And it's a very important aspect of beginning the transplant journey. Because what this does is defines the patient's readiness to move forward for this big, health or transplant, life-saving transplant. Next slide, please. This is a vigorous slide and it's very robust and it has a lot of information, but I thought it would be really helpful to just kind of lay the foundation for what I'm going to be discussing moving forward, since we're talking about the financial aspect of kidney transplant. So when we think of kidney transplant, we think of all of the health plans and health insurances that cover kidney transplant, and all of them do. And when I say all of them, I'm speaking of government payers, Medicare, Medi-Cal, and commercial managed care payers. And when I think state commercial managed care payers, I'm thinking of your big payers that are either employer group payers, such as your Anthem Blue Cross, your Blue Shield, your Cigna, your HealthNet, Kaiser, United Healthcare. All of these plans cover transplant. But within your coverage, it's very important for patients to understand when you have a healthcare coverage, there are also products or plans that are part of your healthcare coverage. And so the plans can vary. Many patients can be covered under, let's say, a Blue Shield plan, or coverage, and each individual plan or benefits vary. And most all of those plans have transplant benefits, but since transplant is a specific arm of care, it's not generally described in the routine benefits, very detailed. But this information is very helpful to know as you are assigned a health plan. So for example, you could have an HMO plan or a PPO plan. That's very important to know if you're an HMO versus a PPO plan, because an HMO plan requires that you have an established relationship with a primary care physician who is essentially going to be the gatekeeper to determine where you can have your services. And it's typically defined within a network. So there's a referral that is required for you to move forward with services. Whereas if your coverage is a PPO plan type, you have a little bit more flexibility. You can see any providers that participate within that PPO network of preferred providers, and providers mean doctors. Doctors are providers who are contracted, and moving over to the box about contracted, that means these providers have agreements that they execute with the plans to say that I will see members who are also signed up with this type of plan. And then there's a transplant network. This is really, really important for patients to understand in their coverage if they are able to go to the transplant center of their choice or the transplant center where their surgeon or provider or specialist is treating them. Many plans have what's called in-network and out-of-network benefits, which is on the slide, which means that if you go to a transplant center or a provider that's considered in-network, your benefits are going to be at what the described benefits are, and they're going to be at the costs that are published. Whereas if you have services at an out-of-network facility, you may have a higher out-of-pocket expense. And when I speak of higher out-of-pocket expense, those are expenses which are your deductibles, co-insurance and co-payments, and premiums. Because each of your insurance plans will describe a deductible, which is amount that you have to pay out of pocket before your plan starts to cover your healthcare services. And then there's the co-insurance and co-payment amount, which is the percentage of your healthcare bill and any other fees that are set forth by your insurance. So it's important, is this coverage going to pay for my transplant in the network at the center that I want to go to? And is that a transplant center that is in my plan's network? And if I go there, is it considered that I'm in network or out of network? Those are so very important considerations in your plan. And then also in your plan, there is a topic that I will talk about, which is called formulary. And that basically pertains to your prescription medications or any medications, infusions included. And it provides a list of generic and brand name drugs that are covered by your insurance and the copay amounts. So that's very helpful in giving insight as to perhaps what would your out-of-pocket expense be with your medications that are known medications that you're taking now, and maybe medications that may be future medications after transplant. Knowing if you're underinsured or uninsured. Underinsured means maybe you have benefits that are limited, maybe not covering 100% of your transplant services, and perhaps that might be indicative of an additional insurance that you would need to supplement so that your out-of-pocket or share of cost expenses are not greater than what you can afford. And uninsured means the absence of coverage. None of these are barriers. all of these have solutions that can, help ease the burden, but this is information that's very helpful to know. Charity care is also a description, and that could be an individual transplant center will offer charity care solutions for patients who may have limited income or inability to cover their share of costs. And that also pertains to Medi-Cal and Medicaid, their share of costs, and that's also based on income. And authorization, you'll hear that a lot. Authorization, it basically means your health plan is giving permission for you to have the healthcare services you need. And as you embark on a transplant journey, the health plan will be looking, not for purposes of not allowing the services, but ensuring, the medical necessity and the medical readiness to move forward. So it's very important that your authorization is provided, that you have a referral, that you're in network. It's at a transplant network, a center of excellence, as described by your plan. It's with a contracted provider, a contracted facility, and you know a little bit more about what your benefits are before you move forward, which is really insightful to understanding the financial aspect. So this just lays the foundation for what I will be speaking about further on in the slides. Next slide, please. So with all of that information, you're hearing $300,000, $500,000. That's charges. It's not what your insurance has to pay, and it's certainly not what our transplant patients have to pay. But it begs all of these questions. How will I pay for transplant care? Will my insurance cover all phases of my transplant care? And I will say that the majority and most all payers cover all phases of transplant care. Do I need additional insurance? That's perhaps a consideration, and that's when we look at the type of coverage that you have and your co-payments. On my previous slide, there was a box about Medigap and a supplemental plan, and when we talk about Medicare, and we talk about co-insurances, co-payments, and premiums, sometimes additional supplemental coverages can help pick up any of those gaps, leaving you without this exposure, financial exposure. Is financial assistance available? What if I don't have health insurance? My bills are stacking up and I can't pay all of them. How can I get help? It can be very daunting when bills start to come in and the interpretation of the bills is difficult to read because you see charges, you see insurance payments, you see a balance due. You're not quite sure what all of that means in terms of what your responsibility is. Should I change my health insurance? And if so, when? Do I qualify for Medicare? Do I need Medicare A, B, C, D? Even what are all of these alpha characters? What do they mean? And are living donor services covered by my insurance? Well, what if there are complications? Are my medications covered by my insurance? Is Medicare free? These are all questions that we have been met with our patients at one time or another. And I can tell you and reassure patients that no question is a dumb question. It is very, very complex to really translate and abstract all of your insurance benefits and coverage. And it does require, the assistance of resources that can help walk you through that. And those resources are available to our patients. Next slide, please. So I spoke about the different coverage plans, and I gave you the bullet slide that talked about coverage. And I want to talk about Medicare specifically as it pertains to our kidney transplant population. So there was a question about Medicare A, B, C, D. This slide really helps to kind of break that down. And mostly because patients who have ESRD have eligibility for Medicare even before the age of 65. Because we think of Medicare, we think of 65, and that's eligibility, but there's other criteria for meeting Medicare coverage, and that's disability. And in this, for this particular audience, ESRD, which is also having a physician diagnosis of kidney failure. And then there's other eligibility criteria that needs to be met, mostly the work credit requirement For Medicare, there's 4 work credits per year, which is typically earned over 10 years. But there's other options available for work credits and Medicare eligibility. But I think the bigger point to take away is Medicare offers benefits for patients with end-stage renal disease, and there are 4 components to the Medicare, and I'll break that down. So you become eligible for Medicare the 4th month after dialysis. And so when we think of the Medicare Part A is really geared towards your inpatient stay. And Part A covers your transplant admission. And then for any skilled nursing facility care that you may need, home health care, and or hospice care. So when you're enrolled in Medicare, Part A is going to take care of your inpatient hospitalization, except for a deductible. Now, the deductible amount is $1,632 for calendar year 24, and that's subject to change every year, and Medicare publishes if there is a change. Part B is largely intended for outpatient services. So you're coming in for clinic visits, you're having doctor visits, medical testing, lab services, and preventative care, and durable medical equipment. Durable medical equipment is considered like walkers, any orthotics, braces, and devices, and that sort of thing. And with your Part B, there is a 20% coinsurance. And what that means is the charges that are billed, Medicare publishes a fee schedule, what they pay based on the CPT codes. And then whatever that Medicare payment is, it's 20% of that. So if a hospital may bill $500 for a clinic visit, but Medicare's fee schedule says for that CPT code, we are paying $80, okay? And it's 20% of the $80. And that is your Part B. So in thinking of Medicare, if you have the Medicare fee-for-service, Part A and Part B are very important. Part D is your prescription drug coverage. That's also a very important benefit to have. And each of your Part D plans will publish what's called a formulary. I spoke of formulary earlier on this slide. And again, that's the publishing of all of the brand and generic drugs that are covered and the co-payments. And then there is the Medicare Part C. Part C is not part and parcel of the Part A, B, and D from a benefit standpoint, but it is an option for how your benefits can be administered. And by administered, it means instead of billing directly to Medicare, another health plan may say, you know what, I'm going to take and package your Part A and B and D together, and I'm going to manage all of your benefits. And there may be some pros and cons to that in terms of what the out-of-pocket expenses are, but the Medicare Part C is also known as a Medicare Advantage plan. It could be considered an HMO. So when thinking about changing from your Medicare fee-for-service to the Medicare Part C, think about it's like an HMO plan. The HMO plan may have some control over the transplant network that you are having your transplant services are, and it may have some convenience, but that's very individualized and also an option for a member of our enrollees. Keep in mind, there is an open enrollment period for Medicare that starts around in October. And during that time, there's a lot of marketing material that is bombarded. So it's very, very recommended that for any materials that are sent to any Medicare beneficiaries or enrollees, that if there is a decision to change from Medicare fee-for-service or change your Medicare Part C, that you do that with consultation with a transplant financial coordinator or someone who knows where you are having your transplant services. Thank you. Lastly, I talked about the supplemental plan. So those red arrows that I've denoted in the slide is really for your out-of-pocket costs. And if you are able to acquire an additional supplemental plan, that plan will help cover the costs that Medicare does not pay. There's a 30-month coordination period, which means that if you also have a group health plan, meaning if you have a commercial insurance and you have Medicare, which you can enroll in Medicare, with that plan, that there is a period for which that plan remains as the primary payer and Medicare kicks in afterwards. And then post-transplant Medicare covers 36 months post-transplant with the immunosuppressants, which are the lifelong drugs that you will be taking after transplant. Next slide, please. Kidney transplant, Medi-Cal, Medicaid. This is a great plan for our lower income population, for which there is eligibility criteria based on the family poverty level. It is a low cost, no premium or co-payment plan that is offered to our members, and transplant must be at a Medicaid, Medi-Cal transplant certified facility and performed by Medicaid, Medi-Cal certified providers. There are no enrollment deadlines, and there are different tiers of benefits for Medi-Cal: full scope, restricted, presumptive eligibility. Full scope means you have all benefits. Restricted scope is very limited, and it may be to emergent, urgent services. Transplant is not covered under restricted scope. It may be for pregnancies, for minor trauma illnesses, and presumptive eligibility is for a patient who may be already hospitalized and who has no coverage, and for which maybe transplant is needed, and for which early information is submitted to Medi-Cal and Medicaid for consideration, and for a period of about 30 to 60 days, maybe, until that application is processed, that patient is presumed full scope Medi-Cal. But Medicaid, Medi-Cal covers dialysis, all transplant, and medications. And it coordinates benefits with Medicare. So it's Medi-Medi, and Medicare is the primary payer. Medi-Cal is the secondary payer. There isn't reciprocity across states, which means if you're Medicaid and say you live in Nevada and you want to have services in California, there isn't reciprocity. It would be recommended that that individual who chooses to have services in California relocate to California, and then sign up for Medi-Cal in the state of California. So there's very limited reciprocity of benefits across states. And then there's a share of cost, which can be determined based on income information that the patient has provided in terms of whether they exceed or fall below the family poverty level, and based on assets and the ability to pay a share of costs. Share of costs must be paid monthly, and it must be paid before benefits are administered. Next slide, please. So I spent a lot of time talking about the commercial plans and HMO, PPO. You can have an HMO for Medi-Cal, and you can also have an HMO for Medicare. And remember, any plan, any coverage that has a denotion of a product or plan type of HMO is going to be managed by the primary care provider in terms of issuing referrals and authorizations. And so you want to make sure, again, I just want to reiterate that your transplant center of choice, your faculty, or excuse me, your provider of choice falls within the network of that HMO plan. Typically, this type of coverage, I've provided a couple of plan names for an example. So just to kind of give you the idea of what we're thinking about when we're talking about commercial or managed care plans, they're typically employer-based. They can be purchased on the exchange marketplace in California. We're known as Covered California, but it's the affordable care plans where patients have options of different tiers of coverage. Covers all transplant phases. Most of these plans do. They cover your pharmacies, both brand and generic. Again, formulary will give you insight into that. It covers you have deductibles, co-insurance, and co-payments, and sometimes an out-of-pocket maximum. That means your plan will sometimes tell you $2,000 is all you will have to pay out of pocket. It sounds like all you can pay, and I don't mean to minimize that cost. I'm just giving that as an example. That is a very high cost, but it will limit the impact of what you have to contribute financially. There's thresholds that are set at various levels. There are transplant contracts and networks. Again, there is designation as what is a center of excellence. Health plans determine center of excellence based on data and based on quality and cost. In-network, out-of-network benefits, international health, COBRA. COBRA is also a plan. It's a law that mandates that employees, through employers who either have lost employment, reduction of hours, or change in life circumstances, that they have the capability to enroll in this plan to continue their benefits with a payment premium. Out-of-state benefit plans that are offered, so patients who have commercial health plans out of state may have out-of-state benefits, which isn't what you see with your Medi-Cal plans. Travel and lodging benefit and living donor coverage. So that's just a summary of the different types of plans and to give you information about the comprehensive coverage of transplant. Next slide, please. Living donor coverage. Very important. Living donor expenses are covered. The evaluation, if you are choosing to be a living donor, altruistic, which means you don't have a designated donor, that you can do that, and it is covered by the recipient's insurance, and it's also covered by Medicare. The living donor surgery, which is the donation of the kidney, is covered by the recipient's insurance and Medicare. Post-operative care is covered by the recipient's insurance and Medicare, which means that the living donor does not have to exhaust their own coverage for living donor donation. Any conditions related to transplant, that is when the living donor's insurance kicks in, even if it's during the time, let's say, unfortunately, maybe the living donor, goes skiing, breaks their leg and has an accident, that needs to now go in through their own insurance. And donor complications, Medicare and some private insurance plans will cover donor complications for a limited time. And there's also support for living donors through the NLDAC, which is the National Living Donor Assistance Program. It covers travel, lodging, lost wages, and dependent care. And some private plans also cover this, but it's very, very important that financial information is provided so that the National Living Donor Association, in partnership with the living donor, can support the expenses related to donation. Next slide, please. So thinking about medication coverage, because that's going to be a very important part of the journey post-transplant. And many transplant patients may discharge with over 15 to 20 medications. And so this is a very important component of, am I able to afford my co-payments? And so in terms of coverage, your Medicare Part B and Part D will cover medications, both brand name and generic. Under your Part B benefits, your immunosuppressants are covered at 80%. And they could also fall under your Part D benefit if you do not enroll in a Part B. Remember, Part B is your outpatient benefits and pharmacy medications, and it covers dialysis medications. And under Part D has a little bit a different benefit tier. It has what's called a donut hole, which is a threshold of expenses that are shared by the plan and the patient through a calendar year. And once a patient exceeds that threshold, it may change their copayment responsibility. The good news is immunosuppressants are not included. They're very costly meds, so wouldn't push the patient to hit that threshold of the donut hole, which could change their copayment. But within that, there are different copayment tiers and categories in terms of how low your copayment can be to how high it could be and the type of medications. And then Medicare offers an extra help program, which is intended for limited income patients. There is an application submission, which really, really defrays and reduces the co-payments for medications. And your commercial coverages and commercial plans will cover prescriptions. There is a formulary, generic brand, co-payments, and then also Medi-Cal, Medicaid covers medication and specifically, and there are no co-payments. And the good news are co-pay assistance programs are available. There is an organization, GoodRx, that offers assistance for patients. There is HealthWell, and even the pharmacy manufacturers offer co-pay assistance options for patients, and which helps to really, really reduce the out-of-pocket or share of cost for patients. Next slide, please. As you're in the transplant journey, I will say, since I oversee this department of transplant financial coordinators, it's so important for patients to partner with a potential, with a transplant financial coordinator, living donors and patients to really navigate through benefits. Because as I shared with you, there is a lot of unpacking that has to happen with the benefits to really understand what your insurance is going to cover and what maybe you may have to participate. But concerns about your bills and can you pay your bills, concerns about escalating or mounting bills, concerns about financial assistance programs, concerns about your benefits, eligibility, open enrollment period. When should you change? Should you change? What's the best insurance? What's in network here? Or I just need someone to be my advocate. I'm experiencing an administrative burden with my plan and I just need assistance. This is the person at your transplant center in conjunction with your social workers, with personnel at your dialysis centers that can help you to navigate through all of those questions that I had on my prior slide. And what's happening with you with your coverage, and when you make any changes or any life changes, these are the individuals that you want to speak to who can really help to have you in a state of readiness should you have an offer for transplant. If any of the circumstances that I am pointing to in the red arrow impact you in your life in any way, it is very important for you to notify your transplant center. If you change your health insurance plan, if you lose your job, if a medical group changes, if you start COBRA, if you no longer have insurance, if you're newly married or divorced, or if you receive correspondence from your insurance company and you don't understand what they're asking, it's very important to respond because it determines how your insurance company will pay your benefits and the order in which they will pay your benefits if you have multiple coverage. An open enrollment period. Be very, very selective during open enrollment period in terms of what information is being sent to you so that you can make the right decision for your transplant. So there's no interruption of having to move from one transplant center to another. The transplant financial coordinator is a very, very valuable.
Carla, you're muted.
Yeah.
Okay. I'm okay. I'm back on. I think I was muted. At what point was I muted?
Maybe just a few seconds. So you're good now. I think you can pick up from where you left off.
Okay. So I just wanted to emphasize the red arrow and any of these life circumstances that may befall upon you at any time during your transplant journey. Very important to let your transplant center know. And your transplant financial coordinator is a key resource to helping you navigate through any questions you may have with regards to benefits, your insurance, your co-payments, or assistance. It is available to you through a transplant financial coordinator. Next slide, please. I want to share with you all in thinking about a transplant financial coordinator and thinking about a journey and thinking about insurance coverage, a case study. It is a patient of ours, and I am presenting it through you, and I am giving dates because I think the dates are relative to a kidney transplant patient who is on a wait list and what could be encountered in the journey for transplant. So this patient was seen for a kidney pancreas transplant evaluation in our clinic in January of 23. In May of 23, the patient was accepted and listed for pancreas kidney transplant and is now on the wait list as of that date. And at that time, the patient had two coverages. The primary coverage was a Medicare Part A and B, and the secondary coverage was a Medi-Cal HMO plan. So the patient was fully insured and on the wait list for a kidney pancreas transplant. A year later, through routine waitlist surveillance, which our transplant financial coordinators are reviewing coverages, and coverages can change. Your health plan can change month to month. It can change based on a life situation. Identified that this patient's coverage had now changed. They had changed from having a Medicare Part A and B, which meant the patient can go to any Medicare facility, to now a Medicare HMO Advantage plan. And that's a change because now this new plan is now managing this patient's care, needs to be established with a primary care physician, and needs to be okay to continue to have transplant at our center. So we reached out to the patient just to discuss the coverage change that we had discovered. And key point in there was very important, that our patients are able to alert us in advance. And so in July, the patient, after a period of time, followed up and advised that they had had an extended hospitalization, and they had confirmed that they had established care with their primary care provider. But unfortunately, because we did not have the financial authorization, which is the permission from the plan, we had to place this patient on financial hold until we verified the patient had benefits and the plan authorized. So we submitted the list to the health plan for authorization under this new plan, basically telling them this new patient you're managing is going through this transplant journey. And so the plan responded and said, we want additional information. We want clinical information, which we understand that because they want to know, is this patient really ready? And have we done, all of the necessary testing and information and listing packet for this patient to be transplanted. So we urgently fast-tracked that to the health plan. And the plan also updated us. The patient had been seen and concurred with us that the patient was due for a waitlist visit. And so we agreed and said, okay, we would move forward and see this patient. Well, there was an abrupt change of circumstances. While this patient was on the wait list, intended to be transplanted by a deceased donor, the clinical team was advised that the patient may have a possible out-of-state direct kidney pancreas donation, meaning this patient, his own nephew had committed suicide, and that direct donation was pending clinical acceptance at this time. So the family had decided that they would offer organs to the uncle. And so now we were at this period where we had submitted the authorization to the plan, and again, this abrupt change in circumstances. And so the plan advised us that they wanted more clinical notes. So they needed dental clearance, toxicology, a chest x-ray, dialysis compliance, history and physical, just a lot of information. And they needed it by a really tight deadline, which was 8/4/24. So the coordinator escalated this to myself, and we reviewed the case notes. And in fact, I also spoke with the Medicare health plan, and the claim was still sitting in this administrative process. But during this time, this is a patient who'd been on a wait list, and this is a very sensitive situation and a donor opportunity that presented. And at this particular time, I decided to move this forward. I knew that we submitted everything clinically that we needed to the plan, but now I have this situation that, sometimes the rule bending is needed after, reviewing the case, and each patient's transplant case is very different. So all of the plans, all of the requested information was submitted to the plan, 240 pages, expedited. And on July 26th, this patient was admitted for kidney pancreas transplant. We expedited the coordination, logistic coordination, sending a plane to a southern state to bring the organ here. It was the family member and the patient was transplanted. And that patient was transplanted within 19 months of listing. And I offered compassionate administrative approval in advance of the plan approval but knew that we had the robust clinical information to support this, and this opportunity and this selfless gift that this family was offering in a very sensitive situation. There was, that would be my appeal to the health plan of our decision making to move forward. And I think it's just a very important story that talks about how the influence of a health plan and, you know, transplant, the unpredictability of transplant, unpredictability yet exceptional and miraculous outcomes in the transplant journey can happen despite any sort of barriers to insurance. Next slide, please. And this slide offers the resources that are available to patients. And, you know, transplant centers offer financial assistance, charity care, you know, so there's outreach that can happen to transplant centers if there's any concern about, you know, the ability to pay for bills. And basically this list is to let our patients know that there are resources available and to have that voice to speak and to let the needs know so that there are no limitations or no stresses of worry about the financial burden of transplant because there are resources available to everyone. And I think that is my takeaway to this presentation. Next slide, please. Is that there are just an array of resources available to our transplant recipients, potential transplant recipients, and living donors that can be customizable to your individual needs, and that can allow you to go through the transplant process, which is understandably overwhelming, but that can be remedied. And it's just have that voice through your dialysis centers, through your social workers, that is somehow translated to your transplant centers so that you can be heard and you can be assisted with the resources available to you. So I thank you all for this presentation. I hope that it was enlightening, and, you know, if it, you know, provokes questions and answers, I'm available by email or phone. But thank you all so much for your time. And I hope this is giving you some golden nuggets of information to carry forward.
Thank you so much. Yes, more than just some golden nuggets, I'd say a lot. The slides were really, really great, and I feel like we will share those so that everybody can print them or have them and bring them to your transplant center to follow up with your own team. So thank you so much, Carla. Martha, thank you for coming back on. We will move into a time of question and answer. The chat box, the QA box is just so active, so there's lots of questions. Thank you, Martha, for monitoring that. Just to let everybody know, we knew that there would be a lot of questions today, and so today's webinar will extend till 12:15. If you do need to hop off, don't worry, everything will be recorded and shared afterwards. But Martha, I'm going to have you moderate the QA time right now, and you too can be in conversation and take some of the unanswered questions in the QA box.
Thank you, Doris.
So there was a few questions that were answered. And again, everybody's case is very personalized. So, you know, if you're asking about your particular case, we would defer for you to reach out to the clinical team at your transplant center to help you assist with that. Were there any other questions that were missed on here? Oh, there were.
What seems to be of interest, Martha? I'm interested in terms of the audience. What were there any concentrated interest in one particular subject?
Questions about Medicare, living donors. I'm sorry, I was trying to answer all of these questions.
You can also go to the open questions. Those have not been answered.
Okay.
Let's see. Disability, dialysis or transplant? I don't know if you are able
I
to
see
answer that or what to
disability,
ask.
dialysis, or transplant. So that came from Dana.
Yes,
I'd love to give you a little bit more information. I think if you're asking if dialysis or transplant is considered a disability, please feel free to offer a little bit more information so I can answer your question.
the second one was, will we be receiving a printout of transplant services offered at Cedars from this meeting?
Okay, so Franco, thank you for that question. Yes, when you say transplant services, if I can get into the realm of what we're thinking of in transplant services, is that transplant services in terms of financial support through the journey?
So this question was actually submitted by email, so
Okay.
not directly from Franco. So
Okay.
I don't know exactly,
Mhm.
but feel free to, whoever submitted this question, to put that in the chat, or ask it again if you want to clarify.
Okay.
Yeah, but in the meantime, I think we can move on to, and same with Dana, if you want to clarify disability. I'm guessing you're asking if dialysis and or transplant qualifies as disability. Type in your question if you want to clarify that more, but we can move down to D. Gross. What if a patient has a living donor in Mexico and wants to do the transplant in Mexico? Any recommendations how a patient should go about that?
Okay, so if the patient has a living donor in Mexico and wants to do the transplant in Mexico, I would recommend contacting the transplant center of interest and opening up with an introduction to the clinical transplant coordinator to understand how that works, because then the living donor would need to be in contact with the transplant center to go through the evaluation for suitability, donor suitability. And then from there, if the donor is deemed suitable and the candidate is also deemed, the transplant candidate is deemed suitable, then it can be coordinated. But that has to be directly through the clinical transplant team at that transplant center in Mexico. Because it sounds like both the donor and the transplant is intended to be done in Mexico.
Okay, there's another question that Franco typed in from one of our email participants. Is prednisone paid for as another immunosuppressants as immunosuppressants are paid for by Medicare, for example, Rapamune, Cellcept, etc.?
Martha, do you see that question? I don't. You can answer it if you
Says,
want
is
to.
prednisone
Oh.
paid for as other immunosuppressants are paid for by Medicare? So prednisone
Oh,
is
yes.
not considered anti-rejection, correct?
That's correct.
So it would not be covered under the Part B, like the Rapamune or Cellcept.
But it would be covered under
covered
Part
under
D.
Part
It
D.
is covered by Medicare, but it's covered under your
Yes.
Part D benefit.
Yes,
Yes.
correct.
Okay. Thank you, Carla, for your compassion and expertise. Okay, so this next question that Franco wrote also came in from email, basically from somebody who was able to get some financial help with traveling and dental care. They've used up that fund. Their question is there any help that they can get after transplant? They have some dental work and don't have financing. Are you aware of any resources?
Not that I'm aware of. This
I'm
is for
trying-
dental care.
Okay.
Yes, it sounds like it. Yes.
Unfortunately, I'm not aware of any program that would help after the transplant for dental work.
Yeah, so it's post-transplant, but there may be options, and I want to look in that because it's really important post-transplant that patient maintains, good health. And as we know, that dental caries can, contribute to other health problems. So I think that there are resources that may be available in the community. We can look at, there are some resources in some county facilities, some academic institutions offer lower cost care for dental services. So depending on where you are, maybe you can share a little bit more of that, but there are resources that can be available to help you with that. And that's also a concern that can be elevated to your transplant team. Because of course, there is concern about your care post-transplant and caring for your transplant. It's a lifelong process. So the team would also be supportive in that, in pursuing options. But I do know certain academic institutions. We, for example, contract with a dental company for some of our evals, for some of our heart transplant patients. So I do believe that there are resources that can be available for reduced expenses, and even some community or county-sponsored dental care that can assist you to help reduce the financial burden.
Yeah. Thank you. Great answer, Carla. Bring up ideas that we might not have thought of.
Yes.
Another question that was submitted, how much of a financial burden is commonly experienced by the kidney donor, if any? I know you talked a little bit about that. If burden is out of the financial capability of the donor, are there financial assistance options?
Absolutely. And so the financial burden that we hope to reduce for our patients starts in the evaluation period. And I think it's mostly the co-payments as it pertains to medications. But one of the requirements that we encourage for our patients is to have a Medigap or a supplemental coverage, so it helps to reduce, because the majority of expenses, it may be, if your transplant center is far, there is the gas in terms of the transportation, or parking fees, which your transplant center can also offer support and assistance with. But in terms of financial, that I think that is it. It's looking at your co-payments. And one of the suggestions that happens with some of our patients during the eval period is maybe encourage, to have, some little jar savings. If you have this opportunity, tuck away $5 a month here and there while you're on your wait list and in that journey. So you may have a little bit of a buffer. But to answer your questions, yes, there are prescription assistance programs. There are copay assistance programs. And so I think that is the majority of it, because I think with our kidney patients with Medicare coverage, it's any of the Medigap and those out-of-pocket expenses. But you know that you're going to have to pay your deductible. And after your deductible, and depending upon when you enrolled in your Medicare, provided there's no penalties, that is the majority of that burden. But there is assistance that is available for that, and which is offered on that last page. So yes, the answer is yes.
Also, can you talk a little bit about NALDAC, the National Living Donor Assistance? I don't remember the full name, but
Yes.
that's providing assistance for donor. And I believe that's changed so that eligibility is based on the donor status rather than the recipients.
Correct.
Yeah.
And so that program is also a very viable program that requires a lot of effort on the donor in terms of submitting of financial information for screening and eligibility. But again, if that is where there is any disability, loss of work, loss of wages, travel and lodging expenses that are incurred relative to the donor process, it is a very, very viable program that has helped several of our donors. And it requires just the willingness to submit financial information for eligibility and screening.
They
Thank
also
you.
help with dependent care as well.
Yeah, yes. Thank you, Martha.
Yeah, thank you. And we will include that link in the follow-up as well. From Susan, what is the typical cost of transplant drugs? Are they covered indefinitely under Medicare?
Martha, did you want to cover the coverage piece of it?
So the cost of medications can vary depending on your plan. If it's Medicare and the entitlement is due to end-stage renal disease, the medication's covered up until 3 years post-transplant. The cost can vary if it's a straight Medicare or a Medicare Advantage plan. So it just depends on the situation of the Medicare or the Medicare status, sorry. And also depending, so if, let's just say that a patient loses their Medicare after the 3 years post-transplant, and they have no other coverage, there is the new program that covers, that Medicare covers immunosuppressants for those patients. So yes.
Great. Yeah. There was a lot of advocacy work. It took 20 years to get that part passed.
Yes.
So yeah, very excited that yes, because it's much more costly to go back on dialysis rather than to pay for Medicare immunosuppressant drugs to continue past the 3-year mark. I'm going to jump to a question in the chat before I lose it. If a patient has a living donor in another country, okay, so we talked about that. Would the donor be able to donate? Is there available financial assistance for them? So I guess you talked about needing to talk to the center in the other country.
So in the other country, yes. So now that would mean, and I'm assuming that question means you have a donor in another country, but you want to be transplanted here. So if I use that scenario, some transplant centers offer an international health office, for which we do. And in the international health, a international donor can be considered. There could be challenges with the international donor because there is the evaluation aspect and the donor suitability evaluation screening and, contact that needs to happen with the donor, as well as, it's just that whole aspect of the maintenance. Would the donor be able to have, the screening out of country? Would the screening meet the standards of the transplant center in terms of the diagnostic testing? Would the donor need to come here? So there's some logistics coordination that need to take place, but can certainly happen. So with the right logistics, and with the right willingness between the donor and the recipient, it can happen if that international donor and the recipient is in the States and maybe the donor is, out of the country. It can be coordinated, but it does require a lot more effort in those scenarios.
Yeah, I can imagine.
Mhm.
Thank you. Annette is asking, if I need to choose a transplant center, does the cost of the surgery vary between centers? Good
Absolutely.
question.
That is a yes. It depends on, the geographic location of the transplant center and, really just the charge infrastructure of the transplant center. So the answer to that is yes.
And this is from an anonymous participant. I suggest talk about post-transplant costs, particularly meds. It's very important to understand the formulary of the carrier. This participant pays $1,000 out of pocket per year just for the immunosuppression. Also, in her case, most of the meds prescribed post-transplant were eventually stopped. Most of the other meds are now over the counter. You want to comment on that?
Understood. And that it seems to be very specific to your health plan, your benefits, the formulary, which determines, whether you're issued generic or trade drugs. So I think a lot of it really depends in looking at your benefits and what those particular meds are and what your co-payments are to each of those. And so I think I did see that you were eventually weaned off those meds, which is wonderful. It means that your recovery post-transplant has been successful. But to answer your question, and since I'm not looking at each individual plans and benefits, I provided some information that really talked about your tiers of co-payments based on your plan benefits and your formulary by your carrier. So I hope that's helpful to understand that or to respond to your concerns.
Thank you. Let's see. Another question from an anonymous participant. Are the antiviral and antifungal meds covered under Medicare?
Yes, those would be covered under your Part B.
Okay. Thank you. And then Kathy has a comment. She's had 2 transplant first 20 years in which the dialysis center billed $24,000 every 2 weeks. Medicare picked up after 3 months. Her eventual transplant saved the government hundreds of thousands of dollars. Any advancement in reining in some of these transplant facilities that make money from dialysis centers that may be to the detriment of patients? I don't know if you want to comment on that.
Yeah, we don't have an affiliation with a dialysis center. So typically dialysis centers are standalone. And, their billing and their reimbursement is within the dialysis centers. And so that would be my response to that.
Let's see. Okay, I think those are all the questions. Did I miss any in the open question section? Martha, were there any questions that you answered under the answered section that you want to highlight or talk in more detail?
Let me look here. So one of the things I just wanted to make clear is that for Medicare, it's based off work history. So you have to have that work history in order to qualify for Medicare. There's a misconception out there that, oh, just because I started dialysis, I'm going to get Medicare, and that is not actually true. So just make sure that you call the Social Security office and find out how many credits you have to see if you qualify. That will be the deciding factor. Also for making sure that once you have your Medicare, if you have an employer-based policy, that there's a 2.5-year wait time before Medicare becomes, or coordination of period time before Medicare becomes primary. There's also a misconception that, oh, I have Medicare, it should be primary, and it's not. There's the coordination of benefits of 2.5 years from the start date of dialysis before Medicare will become primary. And do not get rid of your private insurance, because your Medicare, if it's due to end-stage renal disease, it will be temporary coverage. So we don't encourage anybody to lose their private policy.
Yeah. I remember how incredibly overwhelming this all was. It just felt so complicated, when I had my transplant 9 years ago. And also just, a comment about for young people who are diagnosed early and, let's say they're 19 or 20 years old, they don't have that Medicare coverage because they don't have the work history, but they don't have the work history because they're sick and can't work. So I realized that can be awfully frustrating. And overwhelming.
If I can mention one more thing about Medicare as well. So let's just say that you have not worked, but your spouse has worked. You may borrow those benefits. And I think that that is not really widely known out there, that you may borrow your spouse's credits in order for you to qualify for Medicare. So
can that be extended, Martha, to dependents as well? Because in this instance,
I've seen it for spouses and for minor children.
Okay. All right. Maybe one last question. How about this one? If a patient was listed for a transplant and lost Medicare insurance because he has commercial contracted insurance, would there be any issues with his transplant process? Will he be delayed?
Should not be.
There would not be a delay, because in this instance, it sounds like the patient had two coverages. Curious about the loss of the Medicare coverage, especially if it's for kidney transplant, because typically that's, seated and rooted. But in the instance, that would be communication directly with your transplant financial coordinator, so that your secondary plan, whomever has been sort of administering the benefits, and let's say it's Medicare, and now you've lost Medicare, your commercial plan needs to be brought up to speed as to what's going on. I mean, there are really no more, I think we've, in the insurance and health plan, the sort of issue of pre-existing condition has, been remedied. But it's very important now that your transplant center needs to supply clinical information to your group health plan to let them know this patient is in this very catastrophic phase of the benefits. Because as I mentioned earlier, you've got your medical benefits, and then transplant is a very special arm benefits, requires different case managers to manage it. And so now what needs to happen is that shift to supply your health plan with this information so that they're up to speed and there's a readiness to issue authorizations for you to be waitlisted, if you're in that waitlisted status or otherwise, without any delay or disruption of where you are on the wait list.
Yeah. Sounds like a lot of moving parts and things change constantly and having to stay on top of it can be just incredibly overwhelming.
And we
But
do
thankfully,
see that. Sorry, we do see that patients, sometimes their employers change policies, or maybe somebody can't afford to continue to pay the Medicare premiums. We do see those scenarios, and there shouldn't be an issue. It's just submitting the clinical notes and the request for authorization from the secondary now becoming primary insurance, and getting that approval if required.
And we love when our patients call us and say, well, guess what? I've changed plans. Or guess what? My insurance company sent this letter. They may send a letter that seems really inconsequential. They may say, are you over the age of 65? Or you or your spouse? Does your spouse have coverage? And you're thinking, why are they asking me that question? It's a very important question because there are rules and regulations about the coordination of benefits for your health plans. And sometimes if patients don't answer, they will suspend benefits and they won't pay claims. And so it's very, very important. I will just reiterate and stress, if you're not understanding what all of that information is, please make sure that you respond and then reach out to the resources who can assist you with responding so that there's no interruption and the bills aren't coming in, which then becomes a stressor. And we're looking to relieve the stressor of the financial aspect and for you to just have the sole focus on just your health maintenance and care, both pre and post transplant.
Wonderful. Okay, well, that's the perfect way to end. And Martha, if you have any last 30-second words you want to leave with our audience today, you can share that now.
Please make sure you reach out to your financial coordinator they are your point of contact for any insurance issues, billing issues, and it is highly important that you reach out to your financial coordinator at any point during your pre-post waitlist time. There's always going to be a financial coordinator available for you.
Okay. All right. Well, thank you both so much good information and so much that we can take away with us. We'll share all the resources. Thank you, Carla. Thank you, Martha. Thank you to our webinar planning team and everybody in our audience for your questions and your participation. We will share the recording, the resources, unanswered questions, although I think we answered pretty much all of them. We'll have another webinar as a reminder next month on the 18th on Medicare. So we'll talk again about Medicare and go into an even deeper dive. We have another speaker who is an expert on Medicare and ESRD and stage renal disease, basically anybody with kidney failure, not just transplant, but going through dialysis as well. So please fill out the feedback survey. We want to know the topics that you are interested in hearing about as we plan out 2025. So thank you, everybody. Be well, have a great afternoon, and we'll see you next month.